Hi, everyone. My name is Zohair Chaudhry, and it's a pleasure to be here. So, today we will explain in a lot of detail about what International Health Regulation, the revised International Health Regulation 2005, and the various components within this document. So, the document has 10 parts, as you can see in here. The first part focuses on the definition, purpose and scope, principles, and responsible authorities. The second part focuses on the public health response. Third part on recommendation. Fourth focuses on international point of entry. And fourth, again, public health measure divided into general provision as well as special provisions for ships, airplanes, and other operators. The third chapter focuses on the travelers, and then the fourth chapter focuses on the goods, containers, and other loading areas that potentially needs to be regulated as a public health measure. Then part 6, it's about documentation. Part 7 about specific charges. Part 8, general provision. Part 9 focuses on experts, emergency committee and the review committee, and a roster of all of the specific people. Finally, the last part is the final provisions. So in IHR, as all of the state parties signed, they agreed to do basically this 6 main things in summary. So they need to designate a national IHR focal point, and this is described in Article 4. Then they need to meet the minimum requirements to detect, assess, report, and respond to public health events detailed in the Article 5, 13, as well as Annex 1. Then develop a framework for notifying WHO within 24 hours of a potential public health event of international concern or FIC. Further discuss in Article 6 under notification. Then to support disease detection and control at designated ports of entry and borders. This is detailed in Articles 20, 21, and 23, which focuses on point of entry. Then the last 2 main things that are important are to provide technical, logistical, and financial support among state parties and with WHO to facilitate implementation of all of these measures and core capacities. This is detailed in Article 44 about collaboration and assistance, and then conduct a self-assessment and reporting to WHO, which is an evaluation status, and you'll see how different provisions have been put together over time. And one of them is SPAR, S-P-A-R. So Article 4 talks about designating a national IHR focal point. So the responsible authority must designate this national IHR focal point. This focal point of communication must be available 24/7 by telephone, fax, email, and cannot be an individual person. It is the responsibility of national focal point to evaluate risk of an event occurring within its border and notify to WHO of a potential public health emergency of international concern. This focal point will also respond to WHO request for verification of information of such event and support field investigations, provide early diagnosis, and provide technical guidance for timely and effective response to such events. Here is actually a good summary of the notification through the national focal point, which is detailed in Article 6. You can see that at the national level, state parties are required to assess all urgent events within their territories by using decision instruments within 48 hours. So, and this will be detected by their national surveillance. And at the IHR, once the information comes in, they'll evaluate that within 48 hours. If they find that the event meets the criteria of to be notified to WHO, within 24 hours, they must notify WHO of this specific event that occurred within its border. Such notification will include details of any health measure employed in response to the event, as well as accurate and sufficiently detailed public health information available, including case definition, laboratory results, and number of cases and death. In this diagram, you can see the various linkages between WHO and national IHR focal points. So in here, you can see the national IHR focal point. Each country will have that. They'll be in constantly in collaboration with the WHO IHR regional focal point, which in turn will be in touch with the Director General of the WHO. And this is a two-way process between the IHR regional WHO contact point and the national focal point, constant communication. And you can see in here that the responsible parties they'll be that is designated as a national focal point for each state. They'll be available 24/7, as mentioned here, under Article 4, and then Article 6 talks about the notification process and how that notification will move through the system in here. It is the responsibility of this national focal point to evaluate risk of an event occurring within its border and to notify WHO of a potential public health emergency of international concern. The IHR also requires states to strengthen core surveillance and response capacities at the primary, intermediate, and national level, as well as designate international ports, airports, and ground crossings, and build capacities for such reporting. The national focal point will coordinate with all of these local and community units and have a joint collaboration going on. This is how the system may look like for the United States. The United States focal point, national focal points, is the Health and Human Services Secretary Operations Center. And CDC, even though it's not that and it is not a designated center, it does work with other federal agencies to support IHR 2005 and its implementation. In here, you can see the various federal level agencies. They all work together for an event assessment, and they report to the national focal point, which in turn share information with other government units as well as other international stakeholders, including the WHO. And then if an event meets the notification criteria, it is the responsibility of this national focal point to notify first the WHO within 24 hours, and then any other units that also need to be notified in order to continue acting on the specific event moving forward. So Articles 20, 21, and 23 focuses on points of entry, and a point of entry, or POE, is defined as a passage for international entry or exit of travelers, baggage, cargo, containers, conveyances, goods, and postal parcels. The point of entry provisions in IHR 2005 are designated to minimize public health risks caused by the spread of diseases through international traffic. Three types of point of entries have been designated. One is international airports, second one is shipping ports, the third one is ground crossing. And IHR requires state parties to strengthen core surveillance and response capacities at the local, community, level, intermediate level, and also the national level, but also at all of these designated international ports, airports, and ground crossings as well. So what are these minimum core capacities that must be developed at points of entry? So these capacities must be present at all times, the one listed in here. Appropriate medical service, including diagnostic facilities, access for transport of ill travelers to an appropriate medical facility, provide trained personnel for inspection of conveyances, and finally, implementation of appropriate levels of hygiene and sanitation, as well as ensuring effective vector, rodent, and environmental control measures at points of entry. At the POE, the authority must be able to respond to events. For example, if a suspected traveler poses imminent public health risk, on arrival, the travel has to undergo the least invasive and intrusive medical examination that would achieve the public health objective, vaccination or other prophylaxis, additional established health measures such as isolation, quarantine, or placing the traveler under public health observation that prevent or control the spread of disease. In this case, the state party must provide adequate food, water, appropriate accommodation, and clothing, as well as protection for baggage and appropriate medical treatment of the suspected traveler. Article 5 and Annex 1 discusses the surveillance of core capacities. So surveillance program must meet minimum requirement to detect, assess, report, and respond to public health events. State parties must develop and implement plans of action to ensure that these core capacities are present and functioning throughout their territories at all of the level, local, community level, as well as the national level. And so the IHR requires that all countries have the ability to, one, detect, make sure that surveillance system and laboratories can detect potential threat, assess, work together with other countries to make decisions in public health emergencies, report specific diseases, plus any potential international public health emergencies through participation in a network of national focal points, and finally to respond to public health events. The 15 core capacities that needs to be implemented are shown in here, and they are nicely clarified in the document known as SPAR, 2021 SPAR. And based on the provisions of Annex 1 of the IHR, a group of technical experts identified 10 core capacities that need to be monitored, and they're listed in here from C1 to C10. And all of this, so it was proposed that all of these capacities would be assessed at the entry points into a country, C11, and all of this would be relating to 4 specific hazards, such as zoonotic disease, food safety hazards, chemical hazards, as well as radiation hazard. And with respect to methods of measurement, a state party questionnaire, also referred to as IHR monitoring questionnaire, is sent annually to national IHR focal points for data collection. It contains a checklist of all of these 15 core capacities with 20 specific indicators that have been developed to assess the capacity of each of the country, and together they are known as State Party Self-Assessment Annual Reporting, or SPAR. In here you can see this the website version of that, which is eSPAR. Each country can log in and access the website and report report annually all of the development within those 15 core capacities, C1 to C15. With respect to timeline to meet surveillance core capacities, as the IHR came into force in 2007, by 2009, member countries complete an assessment of the ability of their national structure and resources to meet minimum core capacities. So 2009. By 2012, member countries should achieve the required minimum level of core capacities unless WHO grants an extension. By 2014, and of 2-year extension and achieving core capacities unless an exceptional circumstances exist and a further extension is granted by WHO. And then after a 2-year extension in 2014, we found that 64 countries reported fully achieving the IHR core capacities, 64 countries, and the remaining 130 countries did not achieve the minimum core capacities. And so it was important to continue following up to assist in developing such core capacities. By 2023 updated, we can see that in some of the specific capacities, C1, for example, we are seeing significant lacks. Also for C2, C3, C4, especially in some of the regions such as Africa and maybe in Latin America and also to some extent in Asia as well. And on the other hand, some measures such as surveillance, it seems like that countries are doing pretty well. And then also in here, some countries are doing pretty well in here as well. And with respect to the average capacity per region, the region that is doing relatively well is the European region in general. 75% achievement has been attained. That's a score. Whereas Africa is about 52% score. Asia, which is Western Pacific region, which is here 72%, and then the remaining world, it's below 70% achievement. With respect to main challenges is the C1, C14, C15, and C6, which essentially is the policy, legal, and normative instruments for implementing IHR. C14 is about chemical events, C15 is about radiation emergencies, and C6 is about human resources needs. On the other hand, main strength is surveillance, which received about 83% score overall for the globe. Laboratory, 74% global score. Health services provision, 74% global score. And health emergency management, about 72% global score. So we can definitely see that significant improvement still needs to be made, even though right now we are in 2023. With respect to collaboration and assistance, this is another very important provision under IHR. State parties will collaborate with each other in detecting, assessing, responding to health events under IHR, facilitate technical cooperation and logistical support in developing, strengthening, and maintaining public health capacities required under IHR, as well as mobilize financial resources to facilitate implementation of the obligation under IHR. Collaboration under IHR Article 44 may be implemented through multiple channels, including bilaterally, through regional network and the WHO regional offices, and through intergovernmental organizations and international bodies. So IHR provides for cooperation between WHO and other competent intergovernmental organizations or international bodies in the implementation of these regulations, such as FAO, which is a food agency organization, Food and Agriculture Organization of the United Nations, also the AU and the Asian Regional Agency, as well as the Office of International Office de International de Epizooties, or OEI, which is also known as the World Organization for Animal Health. In here, also government and other banks such as the World Bank and the IMF, which are also part of the development agencies, they can also provide required assistance in implementing some of these IHR regulations. Beside that, NGOs, which is the non-government organizations, industrial association, and foundations, also play a very important role in implementing the regulations. Okay, so that's all in here. Thank you, and we'll see you next time.